Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from the USAID-funded Health Policy Plus project. I am delighted to welcome you to today's webinar on Evidence to Action, Advancing Universal Health Coverage in Cambodia. We have a great broadcast for you today, and we'll begin with just a few announcements. First, this session is being recorded, and we will post the recording to the HP Plus webinars page. We would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and they will be read aloud when we pause for questions. Also, these web conferencing platforms are getting an unusual amount of traffic these days with back to school. We ask that you bear with us in case there are any glitches with the technology. Finally, we ask that if you are not speaking, please mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. And now let's meet our panelists. Next slide, please. So first we'll hear from Dr. Sunita Sharma, Project Director for HP Plus. Then we'll hear from Srishant Prabhakaran, Country Activity Manager for HP Plus Cambodia, followed by Robert Kolsar, Senior Health Financing Advisor for HP Plus. Then we'll hear from Dr. Bart Jacobs, Senior Social Health Protection Policy Advisor for the Social Health Protection Network. And then we'll wrap with Dr. Narith, Deputy Secretary of State and General Secretary for the National Social Protection Council. So we have a really exciting panel for today, and we're really excited to get started. And we'll go to the next slide just to preview our agenda quickly. So we'll be starting with the background and context, then discuss analytics to advance UHC in Cambodia. Then we'll look at stakeholder recommendations, then moving the evidence into action, and then we'll have time for Q&A. And now that we've previewed our agenda, it is time to jump in. So it's my absolute pleasure to hand it over to my colleague, Dr. Sunita Sharma. Sunita?
Thank you, Bethany. Good morning, good afternoon, and good evening to colleagues and counterparts across the globe. I'm delighted to begin this webinar about Cambodia, featuring some of the work the Health Policy Plus project has done to support the Royal Government of Cambodia, with some observations about the broader challenges in making progress towards UHC. We have been talking a lot about safeguarding the commitment to the UHC agenda during these complex times of the COVID-19 pandemic. As new resources are deployed for the pandemic response, we have opened new channels of funding as some country budgets are stressed. Even before these, countries faced a fragmented health financing picture, and with too many schemes purchasing services, pooling small, inefficient pots of funds, and their health sector reform process lacking sound institutional arrangements. As HP Plus, we have been involved in the core discussions, as in Cambodia, of improving use of evidence to address these issues and tackle the need to integrate vertical programs, increase data availability and transparency, and implement information systems reforms to support UHC. Our approach as a project highlights the need to do things differently, to tackle the hard problems on the road to UHC, such as how to make sure the right evidence is available to decision makers at the right time in the reform process, or implementing key enabling institutions and systems that will allow reform proposals to launch and succeed rapidly once approved through the political process. And what we know is that good policy needs time. Indeed, our shared journey with the government of Cambodia shows how both evidence and systems are coming together. Cambodia still faces some key next steps and key decisions. We will hear more about it in this webinar. Questions such as, which population should be targeted for insurance coverage expansion first? How should revenue be raised for health insurance schemes in a way which is equitable and feasible? How should health systems and health schemes purchase from both public and private providers? And how should they balance between rates that are fair and those that are affordable? And how do we ensure quality of care as we expand these schemes across levels of the health systems? HP Plus has been supporting the development of policies and institutions, information systems, and evidence for this complex reform agenda in Cambodia over the past 3 years. We have been working with the key government agencies and development partners, and we will hear from both in today's webinar. The quality of evidence we provide matters. Publication of HP Plus-led analysis in peer-reviewed journals speaks to the expertise we have deployed and the credibility of the shared work we have done with our key government technical counterparts. In addition to evidence generation, institutions matter. As we all know, these aspects can be very important in creating an enabling environment for reform. HP Plus was there from the beginning to support the General Secretariat of the National Social Protection Council as they developed their institutional arrangements to deliver to the National Social Protection Policy Framework. You will also hear more about how HP Plus has supported the General Secretariat with the development of an monitoring and evaluation system to track progress on key UHC indicators. It has been our pleasure to work with the Royal Government of Cambodia over the course of this program, and HP Plus is confident that we have helped to set up this General Secretariat for continued success along the path to UHC. I will now hand it over to Shri Prabhakaran, the HP Plus Cambodia Country Activity Manager, to provide an overview of HP Plus Cambodia program, the universal health coverage policy environment in Cambodia, and how the program was designed to provide support to social health protection policy implementation. Shri.
Thank you, Sunita, and greetings all. HP Plus has been active in Cambodia since mid-2017, and over the past 3 years, we have supported the Royal Government of Cambodia in making significant strides towards implementation of social health protection policy reforms and increasing sustainable, predictable, and adequate domestic financing for priority health programs and populations. The HP Plus Cambodia program uses an embedded advisor model, with our staff working hand in hand with key institutions to support individual and institutional capacity development and promote responsiveness to government priorities. This ensures our support will have lasting impact. Our program has 3 components. First, we're working with the General Secretariat for the National Social Protection Council to ensure an evidence-based approach to the implementation of the National Social Protection Policy Framework, which is the key policy document driving the UHC agenda in Cambodia. Second, we're working with the National AIDS Authority to support increased domestic resources for HIV and greater integration of the HIV response into the health system. And lastly, we're working with the National Center for TB and Leprosy Control to support increased domestic resources for TB, improved strategic planning, and more robust TB management information systems. Today's webinar will focus on the first component, our work with the General Secretariat to support implementation of the National Social Protection Policy Framework. We apply a variety of methods to support effective UHC policy implementation. In this presentation, you will hear about how HP Plus is working with government counterparts and other development partners to consider the policy environment, conduct data analysis and evidence generation, translate that evidence into policy, and advocate for policy implementation. I'd now like to provide a bit of background to the policy context in Cambodia. There are a few seminal documents put forth by the government over the past few years that highlight their commitment to the UHC agenda and detail government priorities that have guided our support. These documents present a coherent agenda and highlight the government's view that human capital development and social protection are essential elements for Cambodia to reach upper middle income status. The rectangular strategy is an overarching document highlighting the government's strategic vision for the country. Human resource development is considered the #1 priority of the rectangular strategy, and within the 4 priorities for human resource development, 2 relate to health and social protection. These are Pillar 3, improving public health care and nutrition, and Pillar 4, strengthening gender equality and social protection. Together, these pillars prioritize efforts to expand the coverage of existing schemes and integrate social security operators, uplift the quality, safety, and effectiveness of health services, and strengthen existing programs to better serve poor and vulnerable groups. This leads us to the National Social Protection Policy Framework, which lays out a vision to construct a social protection system with inclusiveness, effectiveness, and financial sustainability as the tool to reduce and prevent poverty, vulnerability, and inequality. Its focus touches on many of the issues Sunita identified earlier and that my colleagues will explore further, namely, developing and expanding social health protection schemes to achieve UHC, improving the quality of healthcare services and strengthening mechanisms to promote service quality, and operating health insurance schemes through a single operator mechanism to ensure effectiveness and equity and to reduce fragmentation, administrative costs, and benefit inconsistencies. Lastly, the National Strategic Development Plan details near-term priorities, including a target of 65% of the population being covered by social health protection schemes by 2023. These key documents guide the evolution of Cambodia's 4 functioning social health protection schemes: the Health Equity Fund, which targets the poor, the Formal Employees Scheme, the Civil Servants Scheme, the Health Equity Fund for Informal Worker Scheme, which offers coverage to a special category of individuals, including part-time and seasonal workers. HP Plus support to the General Secretariat is designed with capacity development and sustainability as key tenets. Our embedded support commenced in January 2018, which allowed us to help prepare the groundwork in advance of its formal operationalization after the election in August 2018. HP Plus has also been able to support the development of a research team at the General Secretariat. This team has undertaken analyses to assess options to advance the UHC agenda. Many of these analyses informed the development of a health study, which was finalized in January 2020. This comprehensive study and its recommendations support advancing the social health protection agenda. Lastly, HP Plus has supported the development of an M&E framework and UHC indicators that underpin the M&E system that is currently being developed to provide the General Secretariat with visibility on progress on the social health protection agenda. This system contains both a data entry interface for use by line ministries and dashboards for the General Secretariat to track progress on key UHC indicators. This visibility will serve the General Secretariat into the future, allowing them to identify gaps and shape their priorities going forward. I now hand it over to Robert Kolsar, HP Plus Senior Health Financing Advisor embedded at the General Secretariat.
Thank you, Shri, and welcome to everybody on the line joining us today. I'm going to jump right in, and I'd like to start with a short overview to help frame the analyses that were undertaken to support and advance Cambodia's journey to UHC. This will also provide some additional context for the research highlights I will share. First, we are all very much aware that UHC is a complex topic and each country's path forward is unique. There are many competing ideas and approaches, and some may initially sound good, but don't measure up when one takes a deeper look into the context and the evidence. As noted by Sunita, to build consensus on the way forward, we need to be prepared to answer many tough questions. For example, what are the strengths and opportunities with the current schemes and how can those be built upon? Who doesn't yet have access to a coverage mechanism? Who's considered vulnerable? How can we rationalize a contributory or non-contributory approach? And how much will it cost to expand population coverage? These are some of the questions which require an informed, evidence-based response to build consensus, to support the formulation of actionable policy recommendations, and engage decision makers. We analyzed the Cambodia socioeconomic survey data to corroborate our understanding of healthcare seeking and out-of-pocket expenditure, focusing on the rural poor, the primary target of the Health Equity Funds, or HEF. HEF is by far Cambodia's largest social health protection scheme. It was established to improve access to healthcare for the poor and currently provides a type of insurance to about 2.6 million people, or about 16% of the population. The scheme reimburses public health facilities for user fees that are normally paid by the patient with the aim of eliminating out-of-pocket expenditure. First, we can see that the overall health service care seeking in the public sector is rather low. Less than 1 in 5 patients first go to the public sector for services, and paying on average about $38, which is statistically the same as the average out-of-pocket expenditure in the private sector. We also found that over 2/3 of the rural poor pay for care at public health facilities, paying on average over $11 after controlling for other factors. We also tested the assumption that free access to healthcare incentivizes utilization of public services. On the x-axis, we can see the predicted probabilities of healthcare seeking among rural Cambodians by provider type according to monthly effective income in US dollars on the x-axis after controlling for other predictors. We can see the private sector at the top, shown in red, is the most likely provider. Under that, we can see public sector as the second most likely provider in blue. There is no statistically significant difference across wealth quintiles. We can also see non-medical, which includes pharmacies, markets, and traditional options in green, and international care seeking shown in yellow at the bottom of the figure. HEF eligibility is primarily determined using a nationwide ID poor system. This system combines proxy means testing using observable household characteristics and assets complemented with community-based targeting. Households determined to be poor are issued an equity card. There is evidence of exclusion and inclusion errors related to this system. As I noted previously, HEF covers about 16% of the population. This is less than the proportion in the first wealth quintile, 20% by definition, but higher than the national poverty rate of 12.5%. A recently completed analysis found that less than 50% of equity card holders are under the national poverty line. As half of equity card holders represent about 8% of the beneficiary population, the exclusion gap equates to 4.5 percentage points, the difference between the official poverty rate and those officially classified as poor who hold a card. This means that about 36% of people under the national poverty line, a measure of absolute poverty, do not hold an equity card. Now, turning our attention to the question of who doesn't have access to a health insurance coverage mechanism, we break down the working age adult population by wealth quintile and employment group. We estimate that formal sector employees represent about 32% of working age adults. In principle, this group has access to the government's formal sector scheme. However, we can also see that they predominantly belong to higher income quintile households. Likewise, public sector employees tend to reside in higher income households, while they only represent about 3% of the working age population. By contrast, farmers and self-employed adults represent large population segments, about 26% and 14% respectively, and are primarily belonging to lower wealth quintile households. We can also see that they are less wealthy than their seasonally employed and part-time counterparts, who represent only about 6% and just under 3% of the working age population, and who, in principle, are eligible for coverage under the government's informal worker scheme. There's a lot of evidence showing that in Cambodia, as in many countries, many people are grouped towards the bottom of the wealth distribution. We can think about financial vulnerability as the ability to pay for a healthcare episode without falling into the poorest wealth quintile. This figure shows monthly income by wealth quintile with averages and differences to the poorest quintile. So on the y-axis, we have individual effective income. The stacked bar chart illustrates the income distribution by wealth quintile. Just to the right of the bar, we can see the average income by wealth quintile, with the black boxes highlighting the financial distance between each average and the income threshold for the poorest wealth quintile. Recall from a previous slide that the average out-of-pocket expenditure for people who sought healthcare from a public facility is about $38. This suggests that one health event is enough to reduce income to below the poorest wealth quintile income threshold for the second and third wealth quintiles. We also assess the monthly contribution potential among the uncovered, assuming that the maximum amount an individual could be charged would be the same as the employer paid rate of 2.6% under the government's private employees scheme. We apply this rate to the average income by quintile to calculate a proportional rate. We also weight these rates by the proportional share of total income by wealth quintile to estimate progressive or equitable contribution amounts. These approaches reveal severely limited potential for revenue generation among the lower three quintiles and raise the question as to if the cost of collection could exceed the amount collected. To help answer questions about the cost of population coverage expansion, we developed a modeling tool to facilitate the simple interactive estimation for three policy alternatives: HEF for all vulnerable groups, and HEF for the uncovered first through third wealth quintiles. The tool enables a simultaneous adjustment for 4 scenario options. The first and second scenario options relate to the inclusion of dependents under the private employee scheme and the civil servant scheme. Dependent coverage under these schemes will reduce the overall pool of uncovered individuals, thus reducing costs associated with HEF expansion to the remaining uncovered groups. The third scenario relates to a rule not to reimburse services that are provided free of charge to members of the private employees scheme at public facilities. These include immunization, HIV and AIDS, tuberculosis and malaria services. These are provided free of charge to the patient to remove access barriers for priority public health services to control the spread of infectious disease. However, non-reimbursement creates a financial disincentive to providers to render these services to members under the private employee scheme, especially as HEF reimburses for these services. The fourth scenario option relates to the reimbursement rates paid to public health facilities in exchange for services rendered. We have 3 rate options: current HEF rates, rates used by the government's private employee scheme, and 70% of full costs. Aligning the lower HEF rates to match the private scheme rates would correct the current 2-tier system, which provides a financial disincentive for providers to render services to patients under the HEF scheme. Under the second policy alternative, the tool also enables the independent variation of HEF coverage expansion by 9 vulnerable groups in start year. The vulnerable groups include uncovered first quintile, second and third quintile self-employed and farmers, pregnant women, children under 5, disabled, older adults, PLHIV, and tuberculosis patients. So a couple of take-home messages. HEF is not yet fully removing out-of-pocket expenditure, which is a barrier to access among the poor. There are population coverage gaps, primarily among the missing middle. Out-of-pocket expenditure is an excessive share of income among the second and third wealth quintiles, leaving them financially vulnerable to health shocks. And as we can see in the figure, a comparison of the current government health expenditure with international benchmarks shows an investment gap in the health sector. The cost estimates for increasing population coverage through HEF expansion would keep government health expenditure well below all benchmarks. Lastly, I'd just like to note that our findings were consistent with other studies which assess similar metrics. Thank you. Now I'd like to pass the role to Dr. Bart Jacobs, who will talk about these findings, complemented by other evidence, have supported consensus building around health financing partners and the formulation of recommendations to advance UHC in Cambodia.
Thank you, Robert, and good evening in Asia, good afternoon in Europe, and good morning in the Americas. The good news is I go a bit less quantitative than Robert. I go more about the process and the means as to how Evidence is used to reach consensus amongst development partners to inform the government of Cambodia. Next slide, please. So the means is what we call the P4H, the Social Health Protection Network, which was conceived in 2007 at the G8 meeting. Now is the G7. That time took place in Germany. And it was a kind of a formulation for an approach to provide a structured way to effectively address UHC issues in host countries, mainly low and middle income countries. So that was to be achieved through stimulating exchange of information and promoting dialogue amongst development partners. Also to have a maximum degree of alignment and complementary. So if also in case somebody there's gaps in development assistance, that we can complement those. And another approach was to use partners' comparative advantage, especially sector affiliation, meaning World Health Organization, for example, is closely affiliated with the Ministry of Health. The World Bank has good links with the Ministry of Finance. ILO has good links with the Ministry of Labor. So together, we can advance a better case for universal health coverage. The current partners that signed up at global level, please note that this, the size or the order of the logos is not a specific order, it's just by coincidence that we arranged like this. So as you can see, the main group of partners are bilaterals and multilaterals, although we also have a couple of governments who joined at global level. There's also global health initiatives like Global Financing Facility and the Global Fund. A couple of development banks like ADB, Asian Development Bank, African Development Bank, World Bank, and then more recently, specialized institutions. Next, please. So the Cambodian chapter, if we can term it as such, consists of 15 bilateral and multilateral organizations, complemented with NGOs working in health financing for UHC. We call ourselves P4HC plus, C standing for denoting Cambodia, the plus denoting agencies that didn't sign up at global level, but which are present within the country, like COICA and JICA and UNICEF, and participating here. So our objective is fairly similar as at global level, and it's to reinforce the capacity of the Cambodian government to provide UHC to its population. And we mainly try to achieve that by maximizing technical and financial assistance through alignment, collaboration, cooperation, and coordination of our activities within the country. So the way we set the recommendations for UHC 2030, first of all, the Ministry of Health asked through WHO the input of development partners into the health strategic plan forthcoming for 21 to 2030. They coincided with HEKIP, which is standing for Health Equity and Quality Improvement Program, which is managed by the World Bank and which is the pooled funding arrangement between the government of Cambodia and selected development partners. They also asked the input of development partners, their recommendations, what to do for the coming 5 years, 21 to 25. So we organized a workshop with all development partners, all making up the P4HC plus, at which 5 agencies made presentations about their suggestions, their recommendations concerning changes and interventions for the country to reach UHC by 2030. Next slide, please. So the first set of recommendations, that's along the 3 dimensions of the famous cube for UHC. So population coverage, service coverage, and we can say financial coverage, which is, in other words, financial risk protection. So for population coverage, first of all, to trying to reduce the exclusion coverage, which means non-inclusion of people who are considered poor, who have missed out for whatever reason, who are not benefiting from free healthcare, to make sure that they covered in the forthcoming years. The social health insurance only covers dependents to date, so it only covers the employees, doesn't cover the dependents. So to make sure that somehow family members of the employees are included in the social health insurance. And then, as Robert pointed out, there's a lot of vulnerable people and population groups that are not included, like older people, people with disability, people belonging to the second quintile to the third quintile. Now, for health service coverage is to have a uniform, affordable package of health services across the two schemes. At the moment, Health Equity Fund and Social Health Insurance employ different benefit packages, whereby the Health Equity Fund is promoting preventive services and rehabilitative services to a certain extent, whereas Social Health Insurance emphasizes curative care. Ideally, these services are available at primary care level, so as close as possible to the population, especially the rural population, through the district health system. That's to reduce opportunity costs and to enable timely access to good, needed quality health services. We also would suggest to make sure that the community is engaged to promote the healthcare and to promote timely care seeking. And then lastly, the non-NCD standing for non-communicable diseases, that the population, that the health sector foresees affordable and sound management of NCDs, as these account for 65% of morbidity and mortality within the country, and up to date, there's little being done for basic conditions like hypertension and diabetes. Now, for the financial risk protection, we would suggest to ensure true exemptions. One forthcoming research indicates that hospitalized poor people spend on average $80 per hospitalization. So to make sure that they get really truly exempted. Again, the rural population seems to be disadvantaged over time, especially when you follow since 2004 up to 2014. So somehow urban population, the incidence of catastrophic and impoverishment health expenditure is very low. And then lastly, also to increase utilization, especially from poor people, as the majority, as Robert showed, seek healthcare in the private sector, which is, we come back to that later, which is an uncontrolled environment. Next slide, please. So another recommendation, a major one, and the links to the next recommendation about strategic purchasing, is to align both schemes, so the Health Equity Fund for the poor and the social health insurance for the formal sector employees, to align the benefit package. So that's one, at the moment, there's an incentive for healthcare providers to prioritize social health insurance beneficiaries because they pay more. The benefit package is also more generous. And as I said, there is less emphasis on preventive services, especially also tend to have the same payment methods and amounts paid to the healthcare providers. So there is no cream skimming, or there is no prioritization of one social protection scheme over the other ones. At the moment, both schemes somehow purchase services, rather they purchase access, but they don't really purchase services against any quality standards. So we recommend to at least set the basic criteria for standards, and then also to align the processes of both schemes, as they have different patient registration system, different billing methods, different verification systems, and different IT systems. So that should feed into the possibility for strategic purchasing, so by which health services are purchased against a certain set of standards, which has been now facilitated by the recent introduction of patient dossiers. So each public hospital should keep a file for the patient describing the diagnosis, also the treatments provided, so they can be compared with standard treatment guidelines. So in this case, we can link payments to the quality provided, quality set by the standard treatment guidelines. Again, the need to align reimbursement rates and also to focus on digitalization of the public facilities or maybe private facilities in case they get contracted. So then lastly, the private sector is the main healthcare provider. 80% of care-seeking episodes are initiated in the private sector. However, it's a very uncontrolled environment. There is no system to check the quality of the services they provide. So the basics should be an accreditation system, which can signal a certain level of quality of care and kind of a filter system for who can provide care and who not. But as long as this is not implemented, as long as the regulation is not enforced, the best is to have a district health system, as is the case in Thailand, to make sure that people are attracted to the public sector, which is somehow a controlled environment. Now I thank you for listening to me. So I give the word now to Dr. Narit, who will explain how this is going to be implemented in Cambodia.
Thank you, Bart, and hello, everybody. I would like to start my presentation by sharing with you about the National Social Protection Council. The council was recently established by the Royal Government of Cambodia, demonstrating the commitment to advance social protections. The council is composed of 12 ministries represented by their respective ministers or Secretary of State, including Ministry of Health, Ministry of Labor and Vocational Training, Ministry of Social Affairs, Veterans and Youth Rehabilitation, Ministry of Education, Youth and Sport, Ministry of Civil Service, Ministry of Women Affairs, Ministry of Planning, Ministry of Interior, Ministry of National Defense, as well as the Council for the Agriculture and Rural Developments. The council is currently being chaired by Deputy Prime Minister, Minister of Economy and Finance. The council is the key actor responsible for the overall coordination and steering on the development of various social protection strategies and policy, as well as developing the social protection system and to ensure a better harmonization of different strategy, policy, and other social protection activities. I would also like to mention that although social health protection is described in the National Social Protection Policy Frameworks as part of the social securities, which is one of the two pillars of our social protection system, in practice, we consider health component of the policy framework is as important as social assistance or even the employment-based social securities. Next slide, please. As all of us can imagine, the journey toward UHC cannot be without challenges. And as previously mentioned, the important ones need to be addressed in order to move forward with the plan. We appreciate technical assistance in finding evidences and building capacity in conducting research, as well as in providing policy recommendations. With that, policy actions has been taken and progress has been made for each action. One of the recommendations provided based on evidence shown is related to the exclusion error in our targeting system. Just to give the backgrounds, our Health Equity Fund provides healthcare service to poor households without out-of-pocket expenditure using the ID Poor system to identify the target groups. So far, the system identified poor households within a 3-year update cycle. With such a system, error cannot be avoided, but improvement have been and continue to be made. Recently, with technical assistance from partners, including government of Australia and Germany, and with the leadership of the Ministry of Planning, a framework to include households who have been missed during the 3-year cycle, and those who have fallen back into poverty due to unforeseen circumstances between the assessment periods have been developed. A household invited to come forward to request an assessment in order to obtain their equity cards. It is called on-demand ID pool, or ODID in short. A pilot was successfully conducted and the nationwide implementation started in late May this year. During the last 3 months, I must say that we have identified more than 129,000 additional households using this ODID. Next slide, please. The second point that I would like to share here is in relation with the evidence-based recommendations on improving transparency and accountability. For this, and as mentioned earlier, a social protection monitoring and evaluation system is being developed and to be finalized later this year with the support from HP+. The M&E system comprises of 3 components, starting with regulations, what we call PRACAS, to implement the system itself. Now a draft has already been finalized. Along with the regulations, an implementation manual is being developed in which indicators are defined with concrete rationales and sources of data to be reported are identified jointly with designated reporting agencies. In fact, a final validation workshop was successfully conducted 3 weeks ago. It allows us to move forward and finalize the manuals as planned. The last component in the report is the reporting system, digitally designed with both data entry aspect and reporting dashboard to display data grouping based on topics such as progress toward UHC, which is the topic of the sessions today. It will be a custom-built software system enabling online data entry from reporting agencies as well as report generations. More specifically, the system will facilitate the collections, analysis, and use of routine service and beneficiary statistics, budget and expenditure data, as well as payment and administrative statistics to enable calculations and comparative analysis of key performance indicators. The reporting dashboard generates key performance metrics visuals, including total beneficiary, population coverage, geographic coverage density, enrollment and loss, healthcare quality score, health insurance utilization rates, efficiency of claim processing, etc. In short, next slide, please. This M&E system is being developed following a well-defined social protection logical framework, respecting the principle of good governance, effective spending, accountability, and financial sustainability as shown in this slide. Here, I would like to highlight that the logical framework illustrates our expected result chains. It also provides us with a structure to define and measure the expected inputs, outputs, and outcome leading to the achievement of our policy goals to prevent and reduce poverty, vulnerabilities, and inequalities. With this, we believe that not only transparency and accountability could be improved, but also to make each institution participating in the effort of building a strong social protection system in Cambodia more visible as well. Next slide, please. To address the issue related to efficiency, we believe that ICT is the solution. Currently, each operator in the health protection has their own information management system, but those systems does not necessarily link with each other, and there are obviously overlapping steps. We developed a strategy to link those systems with the idea of keeping their independency while integrating them to a platform. An integrated health beneficiary registries will also be developed so that the overall health insurance reimbursement can be improved. The process can be streamlined too, and the issue of multiple ID can then be addressed. While we work jointly with NSSF and PCA on issues to be addressed when developing the integration strategic plans, consultation with Ministry of Interior on how to link the health unique ID to the national ID and how to leverage the integrated population identification system were also done. I would also like to know that this integration strategic plan is part of an overall ICT architecture for social protection, which is now being conceptualized under an interministerial ICT technical working group established by the government with the approval of the Prime Minister. The pilot activity to enable interoperabilities of the insurance claim and reimbursement systems has also been planned. Next slide, please. Although points elaborated are not, those points elaborated are not only to address challenges being currently faced, but also are parts of a wider vision of social health protection being formulated. We call it the roadmap toward UHC. This roadmap would indicate directions to be taken to expand population and service coverage, of course, but would also define a common understanding on how to improve service quality going forward and strengthening institutional systems in order to effectively implement those strategic directions. A working group at MEF leadership level has been established to work on that, and the draft will be put for consultations and discussion with other related partners and ministries, including Ministry of Health. With this note, I would like to thank HP Plus for organizing these sessions and for the excellent facilitation. Thank you.
Thank you, Dr. Narith, Bart, and Robert for those insightful presentations. It is great to hear how several analyses performed based on the policy directions laid out in key strategy documents have generated evidence to inform stakeholder recommendations that are now supporting progress on the government's UHC policy reform agenda. I'll now hand it over to Bethany to moderate the Q&A. Thank you.
Great. Thank you, Shri. Thank you to our wonderful panelists. So we will kick off with the first question. How have you managed to link payment of services to the quality increase? And any of our panelists, please feel free to jump in. And you'll just need to take yourselves off mute if you'd like to jump in.
I think that's going to work better if I mute myself, indeed. So I take the liberty to answer this question. Thank you very much. But as pointed out, at the moment, there's not really much from the UHC perspective or the purchasing of quality health services through social health protection schemes. So that still has to be developed, and we hope to move into strategic purchasing. However, I must mention with the HEKIP program, the Health Equity and Quality Improvement Program. So as the name it says, quality improvement, they have a nationwide program which stimulates the delivery of health services, but it's through pay for performance. So that's a kind of a different, that's a system working in parallel with the social health protection schemes. And so they pay for performance, which is assessed on a quarterly basis by external examiners. And according to a score based on structural quality and process quality, the facilities get a certain amount of money every month, which goes through staff incentives. So that's the main process that exists at the moment. So we hope that in the future, there's a recommendation we give to the government that in the future, they will roll out an accreditation system, which is kind of the basic system to indicate quality of care, at least when they sign up. and then that they can go in hand with a system like the quality improvement of the HCKIP, but the nationwide encompassing public and private health facilities. Thank you.
Great. Does any other panelists want to weigh in, or would we like to jump to the next question? Okay, we'll just keep moving. So the next question we have is, what are the key challenges for universal health coverage for healthcare access in Cambodia during COVID-19?
Well, I guess I can jump into try to answer to these questions. Obviously, one of the big challenges here in health system in Cambodia, I guess it would be a resource and also access. When it comes to the normal periods, you know, access and resource has already been stretched to respond to the demand. But while with the COVID-19, focus need to be shared with, you know, being more attention to prevent the infections. Then it means that it needs to take more from the regular, you know, service providing to other population as well. This is one of the very big challenge that I can see, especially during the difficult time like this. But if our other panelists could complement with this, it would be welcome.
Shall I? I'm unmuted, so I can I can talk. Now, it should be noted that Cambodia to date is only about 280 cases, roughly, since COVID pandemic started. So most cases, the last domestic case was in April. So since then, most cases, there are people returning from abroad, or people trying to come back into the country. So initially, there seemed to be a bit kind of panic amongst the population and maybe also healthcare providers, but the government reacted fairly fast and set up the whole system to deal effectively with all these infected cases. But to date, not a single case has died of COVID within the country. And there seems to be, initially maybe it was also the healthcare providers that were reluctant to provide services, but now we see even with Kanta Bopa Hospital, which is a charity hospital providing services for free to especially poor people. There, the number of consultations and hospitalizations went down by 30%. So there are people say that on the one hand, because people have better hygiene practices, they're washing their hands more, etc. There's less incidence of common infectious diseases. Maybe it's also because people are more concerned to go to health facilities because they're afraid to catch COVID-19. So it's uncertain what is really the really cause of reduced service utilizations. That's all we know for now. Thank you.
Great, thank you so much. We've got lots more questions pouring in, so I'll start reading these aloud 2 at a time, and we'll get through as many as we can. So thanks so much to this wonderful audience with your fabulous questions. So first question in the set here is, who will have access to the monitoring and evaluation online system? Would that be multiple ministries or health advocates? And then the second question is, how successful has Cambodia been to harmonize the multiple schemes? So I'll leave it to you, panel, to just chime in.
Hello, this is Robert. So I can respond to the first question. The M&E system is primarily a tool for the Secretariat to be able to pull together the data from the diverse implementing line ministries and be able to understand and utilize that for management decision making. So that's the primary audience. It's also, there's a feedback loop also where the reporting line ministries are able to see their own data. Ultimately, these reports will go up into, or the compilation of this information will be channeled up through reporting to the executive committee, which has representation of all of the line ministries that Dr. Narit mentioned, as well as the National Social Protection Council unto itself. So there's kind of a natural built-in check and balance. There's also an interest to assess the and maximize the amount of information that can be shared publicly on the website of the NSPC. And in fact, under the principle of accountability, we've included within the M&E framework an indicator specifically to measure the amount of information that's being put out through the website, and the idea is that as much as is considered appropriate would go through that channel, but those are discussions that would happen into the future.
Wonderful.
Well,
Thank you, Robert. Go ahead. Yes.
Yes, as for the second question, but before jump into the second question, I would like to add to Robert that the system itself is being developed now. So all these components being described by Robert are the intentions putting into the design. Let me go to the second second question regarding to the harmonization of the schemes, of the different schemes. Well, I must say that this is one of the challenges we are currently facing with the different schemes being managed by different institutions. Nevertheless, our policy frameworks aim to not only harmonize the scheme, but before that, we need also to harmonize operators for different schemes. The intention is to create a single operator for all schemes in the health, in the social health protection, and with that, the harmonizations of schemes should also be followed. This is the short answer that I can give for the question. Thank you.
Great. Thank you so very much. That is all the time we have left for this broadcast. So I just want to give a huge thank you to our absolutely fabulous panelists, all our Cambodia-based panelists for giving up their evening to share with us this incredible work. And as always, we just want to thank you, our wonderful attendees, for your time and attention and also your fabulous questions. We've really, really enjoyed the discussion today. And as I said at the top of today's broadcast, everybody who registered for today's webinar is going to get an email to view the link to the recording within the next week or so. So again, I just want to thank everybody so much, and we hope to see you again next time for our future webinars. Take good care.